Hey there, Teepa.
Hey, Beth. Thanks for a couple things. Number one, doing this, and number two, talking about doing this thing we're talking about. Yeah. So this past week, not this last Monday, but the Monday before this Monday, you did something for us. You want to give us a little sort of background story to what that was and why you did it? Because I call it speaking truth to power. That's my statement, coming from where I come from. You probably don't say it that way. That's me in my history saying truth to power. So go ahead and tell us your side of that.
Well, it is policy and money are power. And that's exactly what it was. So last week on Monday, the Advisory Council on Alzheimer's Research, Care and Services, which is through the Department of Health and Human Services at the federal level, had a public hearing, as well as a bunch of research updates and presentations and panels. And there were 3 topic areas. The first one was COVID-19 and dementia, the impact, racial and ethnic disparities in dementia research. And the third one was advances in identifying biomarkers and implications for care. So we've got a lot of blood-based biomarker research that's coming out, and some risk reduction pieces that are also kind of hot in research. So the really positive, we'll start with positives first. The positive aspects about this is that across multiple presidential holds on the White House, there has continued to be an effort on the part of the Department of Health and Human Services to be transparent and to actually hold these public hearings. So being somebody who's not from a research entity, I am not from a university, I don't have professor behind my name, I actually simply emailed them and said, I'd like to make a public statement on these areas. And they said, absolutely, without hesitation. So there really is a desire on the part of the federal scientists, or the individuals who are not only scientists, but they also are policymakers, and they're individuals who also volunteer their time to talk about what is the direction for dementia research as a broad category, to really be transparent as they can with where public taxpayer money is actually going, and that they should be listening to folks. So
okay, so let me double check on this. Now, how did you know this was going to happen, Beth?
I got on a listserv, and I get regular emails from this group.
How did you get on the listserv?
I knew
what triggered. Oh, you knew something.
Yeah.
You already knew something, and you were already hooked in. So tell me how you already knew something.
So in my past life as a professor at the University of Pittsburgh Graduate School of Public Health, you get on these things and you learn from a few colleagues, and you also see these announcements pop up, or someone mentions it casually in an email. So it's a lot of highly educated white people talking to each other. Insider
trading.
Yeah, and the hard part about it is that it's not intentional insider trading. It's
no, I don't.
It's the same way that the people who got ahead in the past get ahead in the future because they all know each other. It's not nepotism.
It's a good old friend network. I mean, it's a friend network.
Exactly.
It's true. And this goes back to institutional bias.
Yes.
I mean, and again, socioeconomic, whether it's intellectual or whether it's racial, cultural. I mean, you have to be hooked into the system to get information from the system. And unless
to comment on the system, you have to know about the system.
You have to know about the system. So yes, it's open, but you have to know where the window is that you have to go to, and you have to then listen to what the window tells you. And then you have to go around to the other side of the building and then find the other window that you're supposed to respond to, huh?
Yes.
I mean, there's a lot of tap dancing around this, and I'm not being ugly. I'm just, as I speak truth to power, I mean, it's power we don't even sometimes recognize that we have in our hands, that other people aren't given that opportunity. They don't even know about that opportunity unless somebody opens that window and says, hello out there. There's a lot of...
And to speak to that in terms of following up with data, because I'm kind of a head-first data person, the 6 people who spoke, only one of us was outside academic medicine.
Oh. Oh, so pause. So nobody in the academic medicine people, there were no physicians who were speaking who weren't already involved in an academic researchy mode, right?
Yeah, and I didn't check credentials. There was a mix of MDs and PhDs, but almost everyone spoke from this is the research we're conducting standpoint.
So how many people living with dementia were on this presentation?
In terms of the public hearing, no one identified as living with dementia, all identified as a workplace that was associated with the university or myself, who wasn't. And there was, though, other people that came in and out, and it was also a webinar, so there's some people who weren't visible, like I became visible on the panel. So there may have been individuals who participated earlier, because I was a few pieces during the day that I missed, because it was a day-long program, or most of the day.
Yeah. Okay, so me being mean, it's not really me being mean, me just trying to discern how limited is this sort of asking for information, and we end up hearing what we want to hear, or at least most of it, because those who are talking to us are the people who believe in what we're doing and are already doing that. That being said, that then continues to drive the policy in the direction that the policy is going, because we're sort of continuing that process. And the kicker then, though, becomes this thing, which is called the money or the funding. And historically, Alzheimer's always got, and I say Alzheimer's because Alzheimer's was the word that was used. Dementia was not the word that was used. Alzheimer's was the word that was used. And the fight against Alzheimer's, that's the old words that were used, has always been sort of the battle cry to try to get funding. That's how they first got the NAPA Act sort of passed, was to raise enough energy, desire to pursue something. And we call that the quick fix. Have you got the quick fix? It's sort of like, ooh, can I have cocaine? And it's like, wait, cocaine's not good for you. I mean, how about some opium? No. But it's that idea where it's going to be this quick fix. And if we do the quick fix, then the problem goes away. And I think, this whole idea of when you have an opportunity to speak to people who have sort of set the policy, started the motion of the policy, and are excited about where they've come from, which was we got almost no funding, and now there's more and more funding into that research side. I mean, that's exciting. It used to just mostly be funded by private agencies or the Alzheimer's Association. And now there's more funding. And then there was the Alzheimer's Foundation of America that's doing some funding, not the same kind of funding, but different. So now this presentation that you did, so what's your take? So NAPA actually, what does NAPA actually stands for? Because this was the NAPA Act was the phenomena that started a lot of this actually hard in motion.
Yeah, so NAPA is the
National Alzheimer's Project Act.
Yes.
So right away, I see a problem with this.
That was part of my statement, yes.
Speaking truth to power, I see a problem with this.
Right. And I will say this, here's the cool part. So I'm always about looking at this in a very balanced way. And one of the panelists.
Which is why Beth did the statement, not me, among other reasons. I mean, she's much more skillful at that stuff.
Trying to use the front load.
Which is I get too passionate and I get too strong, and then people just turn off. So that's not healthy. That's not, it's courageous to know when you should speak and when you should not speak, and to have someone who has the courage to speak what you would like to say, but no, you shouldn't be the one saying it, because of history and because of relationships. I mean, I'm not on the inside track. I chose actively to never stay on the inside track. I have lots of history of being there to check it out and then going, yeah, no.
Yeah, and I mean, there's definitely advantages and disadvantages of both. So backing up, NAPA, it's basically a program to leverage health and human services programs and other federal efforts to look at the trajectory of research and also the trajectory of, as they call it, ADRD. So it's Alzheimer's disease and related dementias is how this nomenclature has expanded. And the written into that is that they have to have these public hearings. They definitely don't do them under duress. And I will say I was really surprised and also really pleased that one of the few panels that came through was held by Ron Peterson. And this was not known to me when I did this or when I saw it, but was a guy who's at Mayo. He's a MD, PhD. I really like his research and his angles in the past. He's obviously out of Minnesota, but his whole talk for the panel was on language, and they've got a committee looking at the way that we speak about things. So we had sort of a two-part statement that I felt really rolled nicely off of his, and his was at the end right before the public statements. And it had to do with nomenclature, so how we name things, because how we name things drives how we think of them. And especially if part of this way down the line of power is public funding and therefore public voice, this concept of how we're speaking to the public. So if I have a family member and all these weird things have been happening, I got a diagnosis of a movement disorder of some sort, and then they figured it was Parkinson's, and then they figure I had a really late onset mental health issue going on, maybe schizophrenia, the first time in like 52 years of age. And then suddenly I hear it's Lewy body. At that point, do I, as a wife, do I look at my husband and say, Alzheimer's research is my buddy? I don't know. I don't know if a stressed care partner and a person living with dementia that went through this horrific journey of multi-years of getting misdiagnosed, do I know that Alzheimer's is also part of my party? And it just seems absurd. It's the same way that I would say, well, I have breast cancer, so therefore I must go to the prostate cancer website.
Right.
And it just doesn't make sense. So if we're trying to help educate the public, and a big other panel talked about, we have got to, or one of the other commenters is, we've got to fund properly the full diagnoses. That process, that it's not going to be rejected as payments, that it's much easier to go through these panels, that, if we're going to say that and try to push that on the one hand, we've really got to start talking in general about dementia as the umbrella for all these 120 different forms, types, and causes of dementia, and not just Alzheimer's, and the other ones. So language matters,
especially when risk reduction right now, it hinges on vascular disease. I mean, it really is hinging on our understanding of the vascular element that feeds many of the other abnormal formations that kick up.
Truly.
So, understanding the value of vascular health, of health in general, and maintaining wellness and immune health now with COVID. I mean, the idea of risk reduction and management. So Beth, we're running out of time here in this courageous conversation. And so I'm wondering if you have final thoughts. And then what I'm going to ask you to do is, with me offline, I'm going to ask you to actually read the statement as you read it, because I don't want to, I just want you to read that. But I want that sort of as this is what Beth read. This is what Beth created and the team created to drive Beth's comment. But if you had to say, what are 3 messages? Because one reason I wanted us to speak is the NAPA, that act still talks about cure in 2025.
Yeah. Prevention and treatment in 2025.
Yeah. I mean, and there's this little sidebar stuff, just like Alzheimer's and related dementias. It's like cure and stuff that we could do in the meantime. And it's like, wait, let's balance this act. Let's talk about the truth of this and what we could, should, can do, and what we want to do. What do we want to do here? And what PAC wants to do is create an inclusive community that involves anyone who has any connection to the possibility of developing dementia. Not that you have it, not that you're living with it, not that you're living in connection next to somebody in it, but the reality that we're living gives us that opportunity to possibly have something happen to our brain that we would not wish on ourselves nor someone else. So let's develop some basic abilities and understanding about this, just like we are developing it for human growth and development, children developing, people getting old. We're starting to understand it better, but it's surely not a universal. So your
No.
messages, key
Yeah,
messages that
the three core messages that we really felt for the area of federal research and policy, and then trickle down to states, is first of all, we've got to start changing the way that we look at naming. That's our first one. How are we speaking about dementia in general? And really just toss out this idea that we're only going to look at Alzheimer's. It is, not only is it not fair, but it's actually disrespectful. It's not okay. And we're finding that every week, every month, we are chipping away at that number of the number of people that we think actually have Alzheimer's. It's an important part of the puzzle, but it is one piece of the puzzle, and it sure doesn't make a picture. The second area that we're looking at is pulling back from this concept. We are going to find a cure, a treatment, a pill, or even a combo of pills for a form of dementia. Because that's baloney. And any scientist worth their salt knows exactly that's baloney. But all we're doing is repeatedly communicating this. And therefore, we are not getting the entire treatment team at the table. That brings us to the third point. The third point is, if we are keeping our goals set at prevention and effective treatment of Alzheimer's disease by 2025, we are summarily doing the opposite of what we have found to be effective for every other type of umbrella disease. So for example, when you are diagnosed with cancer, no matter what stage, type, form, or cause it is, automatically, by regulation at your state level, because insurance projects are regulated at the state level, to offer, and insurance companies to offer health insurance in the state, you have to do these basic things. You are given a team of individuals who are reimbursed for their services that they provide you for your cancer treatment team. We hear about this, cancer treatment teams, right? It's the only way we effectively treat cancer. Well, when you possibly go to your PCP and you start to think, something's up, this little thing that I've been experiencing might actually be a bigger brain change that is a disease-based, progressive, neurodegenerative terminal illness. It's a lot of words there. You get one person, your primary care provider you're talking to,
who says, you won't really need me until something happens. Here, you can try these. They're probably not, you may want to, I don't know, if you get a chance, get up with, there's some volunteer organizations out there might be able to help your, you'll need a care person, by the way.
Oh yeah, who's your proxy?
Yeah.
And if they're good, they also then say, you really might, you need to get into a clinic and get a full diagnosis here, get a neurocognitive workup. And I have actually talked to many people, many family members, many professionals. So this isn't just family members and you're wondering, do the family members know enough, who've actually gone and had people that have gone to those places and their neurocog workup, they get a full one. And then they're told, yeah, you have some form of dementia, but it doesn't really matter. And these are from neurocog workup. This is neurologists doing these diagnoses and they got a PET scan.
How could you say that? It's like, what, the kind of cancer I have doesn't matter?
Well, no, it doesn't matter. It's just, it's cancer. So therefore.
But wait, aren't there things that I should be doing differently if I have different kind of cancer than other cancers? That's my understanding.
Sorry, and now I'm playing devil's advocate with you. The reality here is that we are not set up to properly diagnose and therefore even treat. So this goal even of prevention and effective treatment of Alzheimer's by 2025, we are not putting together a set of policies that even support just Alzheimer's prevention and treatment, much less any of the other 100 plus forms and types of causes. So PAC's third objective was to, and this was a collective idea. I don't want you to get the idea that this is something I just came up of. We do need a team. And we are looking at that this single goal of prevention and effective treatment really has to be a 5-pronged approach. And it is the same way that other complex diseases have been tackled and successfully managed or treated. The first way is prevention. We've got to have research that is funded and policies that look at how it is we inform and then support prevention of dementia. There's many of these that are preventable on average. The second area is cure. We do need to continue looking for the potential causes then for the cures for the different types and forms and causes of dementia. Absolutely.
Or abnormal protein formations. Perhaps, that's where we're really getting smarter about, oh,
Yeah.
these guys are different. And the gene code that might be
Right.
linked, just like in cancer. Go ahead.
The inflammatory ones versus the, familial ones. Restoration and rehabilitation. So how it is that we have effective services, therapeutic services out there that truly not just augment, but really look at the restoration of skills and abilities. The hard part about this and why this really requires a full prong of this 5-pronged approach is that it changes over time by definition with this disease. It's not like cancer in that way. It's harder.
Yeah. So what Beth's saying is, what do you possibly still have available to you that isn't being used right now, that if we called it up and put it out there, you could have a higher level of ability for a window of time at least, which would change lots of things about your situation, your support network, and the family around you and the services around you, but not if we don't even look for it and don't support it, because you have a chronic condition that's going to get worse. And it's like, well, that's true with diabetes. And look what we figured out about that.
Well, and here's the scary part.
Diet, it really matters.
It matters. And not only does it really matter, and it brings us actually to our fourth point, but when we're talking about dementia, if we're looking at 15, 20 plus years of people living with this disease. We're not talking about this hopeless, arranging chairs on the deck chairs on the Titanic. We're actually looking at, if you're looking at 20 years, now being 48, if I had 20 years left to live, that brings me to 68. If I can change 5 to 7 of those to dramatically alter my quality of life, wouldn't that be worth it? Not only to me personally, to my family, to my community, but also to the bottom line of all my states.
So maybe the Titanic changes where it's sailing and we avoid the icebergs for a while, because even though we eventually are heading to the US, maybe we're going someplace else first.
Wouldn't that be nice?
It's just a thought.
And their fourth one has to do with compensation and augmentation of skill loss. So we do know this disease inevitably. It is part of the diagnosis, and part of the definition is that there will be skill loss. Parts of our brain are dying, 2 of them at any given time, to get this diagnosis. So with an occupational therapy approach, we can actually then do this, support someone when there are skill loss. But look at this. I actually have abilities because I have just a little bit of augmentation. It's really working with your team. And it's not about restoration and rehabilitation. It really is looking at, as losses occur, it doesn't mean all of my losses occur. And that's a very separate field of study, therefore a field of funding. And then the fifth one, this is so important. Just like palliative care and hospice care have become such an important part of cancer, and this idea that you can actually have a good death versus a bad death. And anyone in the field knows huge differences. To die peacefully, happily, as you choose, under your own control, is very different from stopping fighting, giving up, or being in such distress to the very end. So this idea of comfort and palliative care as part of this 5-prong approach is a critical area of research, because right now our hospice providers are given a lot of information on pain management control for people with bone, muscle, and organ failure. What we are not supporting them with necessarily is massive education on when you've got the one organ in your body that controls and manages brain activity and understanding of pain management. How do you help someone and support them in the dying process when the one organ that manages pain is the organ that is dying? Totally different approach to hospice care in dementia care. So that 5-pronged approach, we really believe, is a respectful way, not only for public funding, but it is really calling to the actual scientific evidence that we've got out there on neurodegenerative diseases. And it truly addresses how complex this situation is. And our healthcare delivery, living in silos, treating individual symptoms and individual organ systems, it is not set up to do this. And until we start facing it as a community, that each one of these people need to be brought together by policy, by funding, by research, it's not going to happen. And our families deserve better.
And people living with deserve better.
They're part of the families, is my thought.
Oh, they're part of the family. There we go. Yeah, we've got that. Part of our community, part of our world, part of the life. So Beth is going to give you the statement, and then Thursday we'll we'll be talking a little bit further about when you listen to that statement, let us know what you think. Give us some feedback because we put it out there. We're willing to say it, and Beth will tell you where we said it. But come and be part of the conversation on Thursday, and we'll follow up with more details. Thank you, Beth.
So our NAPA statement from Teepa's Knows Positive Approach is as follows. I'd like to thank the Advisory Council on Alzheimer's Research, Care, and Services and for the opportunity to comment on this important issue in the direction of dementia research. At Positive Approach to Care, we especially would really like to thank Ron Peterson, Dr. Peterson, for his presentation on nomenclature in dementia research. Our statement is specifically on the need for major changes in nomenclature, and as such, research direction primarily focused on a cure for dementia. We need to switch that to a broader dementia health services research approach. So thinking back as we as scientists and policymakers, when we were in the mode for a cure for cancer, we were looking for that magic drug, this idea that there was one cause of these tumor growth as we thought about it then. There was a magic chemical combination we had to figure out. So we started saying, oh, maybe we can prevent these tumor growths. And then we said, oh, wait, but cancer, there's genetic pieces to it. Oh, wait, oh, but some is exposure. Oh, and then we learned, oh, but some of it's actually manageable, like it's a chronic disease. Oh, it's very different. Oh, but then some of it's intractable. As we grew with our understanding of cancer, we moved away from researching a singular cure for cancer to a place where we are now, with incredible gains in the 200 different types and forms and causes of cancer. But to make these gains, we had to acknowledge that our original approach of finding a cure, the cure for cancer, was too limited in scope. Only when we stopped talking more specifically about the cure, that public and policymakers started talking about this idea that care and cure are bigger. Wow, this is really, we needed more seats at the table. And especially we needed to include those receiving treatment, people with cancer and family members. That's the place, that's the only place where we started to make true advances in morbidity or in mortality for all these forms and types and causes of cancer. So now we enter in Alzheimer's. That's only one form of dementia. It has been 114 years since Alzheimer's was first diagnosed. And somehow we're still talking about finding a cure for this one disease and finding a treatment for Alzheimer's. Further, we still fund research and make policy largely without people living with these diseases on every single panel. So NAPA has a goal to, quote, prevent and effectively treat Alzheimer's by 2025. So we believe at PAC that the goals such as this do not accurately drive the narrative around dementia. We believe it actually holds us back in funding and in policy. So for the advancement of quality of care and quality of life for people living with dementia, we believe the goal should not only address prevention and effective treatment of Alzheimer's, but a five-fold balance to address prevention, cure, restoration and rehabilitation, compensation and augmentation of skill loss, and then fifthly, comfort and palliative care. So by creating a goal for all areas of dementia research, we can craft a robust healthcare plan for each person and their care team that aligns with the latest scientific evidence on neurodegenerative disorders, addresses that huge complexity and uniqueness of each situation that our health services community face, and then truly, and most importantly, delivers the care that the public deserves. Thanks for listening today.
Hey folks, thanks for watching. Please like and subscribe to help us spread Teepa's Positive Approach message around the world. And don't forget to click the bell to get notified when new videos are posted.